Back to Einstein's Eyes, everyone. We're glad you're here. This is the channel where we explore the fascinating world of vision and eye health, and really anything technology, innovation, finance, policy related to healthcare. And, we have a special place in our hearts for ophthalmology because we're ophthalmologists. I'm an oculoplastic surgeon and neuro-ophthalmologist fellowship trained in Anchorage, Alaska, at Ophthalmic Associates for the past 30 years. And my co-host, friend and partner and co-resident is Jon Ditkoff.
Hi, everyone. I'm a cornea specialist, general ophthalmologist in northern New Jersey. I've been in practice for 30 years. Carl and I met each other at Albert Einstein residency for ophthalmology. Hence, Einstein's Eyes is the name of our page. And, we're glad you're here. So we're looking forward to learning about a new topic today.
Right, good. Thanks, Jon. And today we're going to dive into an important topic that affects people worldwide, many people worldwide. It's known as narrow angle glaucoma, particularly important for certain groups and certain populations, as well as people who are farsighted. And that means that you have glasses that have a plus number on them for distance. So for distance, remember that. So if you wear a +1, a +2, +3 for distance, you're farsighted. We call a hyperope, that can set you up for narrow angle glaucoma. So narrow angle glaucoma, it's a term that might sound a bit technical to some of our viewers. And Jon, I'm going to ask you to explain it in simple terms.
Sure. So as Carl was alluding to, certain people have a certain shaped eye, and that eye tends to be smaller. So that's why hyperopes are farsighted eyes. So those are the people that really had great vision their whole life. And when they hit their 40s, not only do they start to lose their near vision, they start to notice their distance vision, or they really always had weak distance and near, and they wore, as Carl said, a lens that was a plus lens. So any of those people are at risk, but it could happen to anyone. And the thing is, Carl was using the term narrow angle glaucoma, which is true. There's glaucoma, and there's two general types, but to me, they're really very different diseases. I mean, it's almost like they shouldn't even be called the same thing. So to me, someone either has narrow angles, and that puts them at risk for narrow angle glaucoma, or they have a different disease. And we're not going to talk about that today. But people that have narrow angles are walking around feeling great. They have no symptoms at all. They can see well. They don't realize they have a problem. And that's why it's so important you get your eyes checked. Because at an eye exam, like in my office or in Carl's office, one of the things my staff is checked to do and all the doctors check to do is when we look at the shape of the eye under a microscope, we can see that narrow eyes are narrow. They're actually not as deep or full as other eyes. And when we see that, we're very cautious because one of the parts of an eye exam, as everyone knows, is dilating you. And when you dilate someone's eyes, you make the angle more narrow. So getting back to narrow angles, what is it? It's basically the shape of your eye. It's a disease that affects the shape of your eye, but you can walk around feeling great until you have narrow angle glaucoma, and that's a medical emergency.
This is the cornea or front part of the eye, the clear part of the eye. And then we're looking on a side view schematic, a cross section. This is the iris, can be blue or brown. And here's the junction between the cornea and the iris. And in this area right here at that junction, there's something called the filtration system, where the fluid in the eye that's made behind the iris or the blue or brown part flows through the pupil, which is the opening in the eye, and it filters through this thing called the trabecular meshwork, which is basically an outflow. It's kind of like a sink. The ciliary body is like the faucet. It makes fluid, and then it drains in this filtration system called the trabecular meshwork. And this angle here is what we mean by narrow angle. And it can be narrow, it could be wide. And we determine that with a technique called gonioscopy, where you place a contact lens on the cornea to see. This is the area that we're focusing on today. And Jon is correct. I shouldn't confuse narrow angles with narrow angle glaucoma. Narrow angles are a precursor to narrow angle glaucoma, but it doesn't mean that you'll get the glaucoma. So Jon, you wanna jump in on that?
Yeah. So as Carl said, I mean, a lot of my patients that come in, we're always checking their angle Well, most of the time, it's just a quick look. We can look at the eye with a microscope or even with a pen light, and we can see, like Carl said in this diagram, whether the angle is narrow or wide open. If it looks narrow, then we do a gonioscopy, which is a special technique. It just takes a couple of minutes where we put a lens on the eye, and the lens has mirrors. So the lens will be able to look right into that area to see if it's wide open or if it's narrow. So there are some patients I've been monitoring for years with narrow angles. And I look at them once a year and I put that special lens on the eye and I say, oh, your angle's a little narrow, but it doesn't look like you're at risk. It's fine. We can dilate your eyes. You can take antihistamines. You can do everything normally. And then sometimes patients come in and we look and we say, this is pretty narrow. Like I'm worried that within a year it might close off. Or if they take a certain medication like an antihistamine, which can make it more narrow, or we dilate their eye, which can make it more narrow, it would actually close. And the problem is when it closes, that's dangerous because it doesn't close and open. Once it closes, it closes. And then fluid can't get out, like Carl was showing, normal aqueous flow, there's fluid that's being produced by the ciliary body, that yellow stuff, and it circulates and it goes out the angle. Once the angle closes, then the fluid can't out, it gets more pressurized. So it gets more and more closed irreversibly, and then we can treat that. So, but that's a medical emergency. So for this video, what we're going to talk about is what does a doctor do when they detect a narrow angle? So what I do is I monitor closely, and if I feel, based on my experience and my judgment, it's really a judgment call, that I think that person is at a high enough risk for the angle to close, then I recommend treatment. And the treatment is a laser. It's called a laser iridotomy. It's actually a relatively simple procedure. It's covered by insurance. Takes a couple of minutes to do, and it's a very low risk procedure where we basically put a hole in the iris, in the colored part of the eye. And that works as a safety valve. So that way, if the angle had ever at any point became closed, the fluid would immediately find that other area in outflow. So that person is not at risk anymore. Even though they have narrow angles, they're not at risk for narrow angle closure, which is glaucoma.
Right. And John, I should add,
just so you know, it doesn't hurt. It's risk-free, I would say, except rarely some people can see a little extra light coming in their eye from the hole that the doctor placed. They might get some inflammation or irritation somewhat after the procedure. And then there's really rare side effects that can affect vision, but extremely rare, like pressure and other things like that.
And how does this differ? How does narrow angle differ and narrow angle glaucoma different from the more common open angle glaucoma? So
it's such a common question.
Yeah. So I'll go first, and John, and you can fill in. So open angle glaucoma, the drainage angle remains open. That's why it's called open angle glaucoma. But the trabecular meshwork, the eye's drainage system, doesn't function properly. So it causes a gradual buildup of pressure. Now, in narrow angle glaucoma, on the other hand, as we were mentioning, this involves a physical blockage of the drainage angle, leading to a rapid increase in pressure. And this makes it a medical emergency. And that's why if we see it, particularly in a hyperope or in some populations, for example, Asians have a higher risk, women have a higher risk than men. I believe it's threefold. And Inuit, Native Alaskans, have a higher risk. So ophthalmologists and optometrists watch those populations. And if we see narrow angles, then we'll do a treatment, which John was discussing, the laser iridotomy. And I also wanted to highlight the medication. So besides antihistamines and mydriatics or drops that dilate the eye for, say, a diabetic exam or a macular degeneration exam, decongestants like pseudoephedrine can dilate the pupil. Some antidepressants, like tricyclic antidepressants, and selective SSRIs, which are selective serotonin reuptake inhibitors, can dilate the pupil. Certain medications for an overactive bladder, certain antipsychotic, and drugs to treat Parkinson's also have been known to pose risks. So I did want to mention that. So, John, anything else?
Yeah, so I think it's kind of interesting. When I see patients in my office, this is the way I've always explained this. Hopefully this will help you guys in the audience. It's kind of hard. I can't show you, but you'll get the gist of it. So basically, imagine a room. And we're all sitting in a room, and there's a door, and there's, let's say, a sink in the corner. So imagine the sink is what we call the ciliary body. So the sink is producing fluid and it's going into the room and it's filling up the room with fluid. So that's your eyeball. The sink is the pump. It's pumping fluid in. And imagine there's nowhere for the fluid to get out. That room would explode with water. But there's a doorway. So the water very easily finds a doorway and it goes out the doorway. And then it goes down these little hallways to get to the front of my office. The hallways are the trabecular meshwork. So a person with open angle glaucoma, the room looks normal. The sink is producing fluid. The doorway is wide open. But when that fluid has to get from my office all the way to the front of the office, it has to go down these hallways. Those are like little channels that are a little bit blocked. And like Carl said, in that case, the pressure might go up a little bit over time, very slowly, no symptoms at all. But the eye doctor detects it by seeing that your pressure's up, or we're seeing changes in the nerve, and that's open angle glaucoma. Narrow angle is very different because the doorway, it might not be closed all the way, but it might be 80 or 90% closed. And when we examine someone, we can see that their doorway or their angle is really narrow. So as we're examining them, their pressure's fine, they feel fine, but we're concerned because if that doorway closes or that angle closes, suddenly the fluid in the eye or the room can't get out. So that's why I've always explained narrow angle to my patients. Some of them look at me and say, oh yeah, great. And then some of them I leave the room and my assistant will be there and she'll look at them and say, what the hell was he talking about? So hopefully most of you in the audience were getting it, but it's a really interesting disease. But the good news is, as long as you go into a doctor regularly and the doctor detects it early and monitors and then treats it before it becomes a problem, most people nowadays don't develop narrow angle glaucoma. We see one case a year. Whereas when Carl was in our residency, we saw him every week, right?
Yeah,
I mean,
yeah.
so people coming in medical emergencies with elevated eye pressure, that if they weren't treated within hours, they could go blind.
Right,
now
right.
we see one case a year because doctors are so good at detecting it and people are really good at going for
Right.
eyes.
When we were residents back at Einstein, John, I remember I was up one night all night because we had angle closure. It's always at 3 o'clock in the morning when it gets dark and the pupil dilates.
Yeah.
And I had to monitor it and treat it at Jacobi Hospital in the eye clinic. And patients are throwing up. They're miserable. The eye hurts like crazy.
Yeah.
But we got the pressure down. And then you have to wait for the inflammation to go away before you can do the laser. But you treat it with drops that lower the pressure initially, and anti-inflammatory drops. You should also know that cataract surgery can also help treat narrow angles because you're removing the volume that the cataract takes up, and that allows for the iris angle to spread open or widen. So that's another benefit from cataract surgery besides just improving your vision. So really, what lifestyle adjustments or over-the-counter products should you be cautious about? And this gets back to what we're talking about. You want to read the labels about causing the eyes to dilate, like antihistamines or decongestants. You want to let your doctor, dentist, or anyone, a pharmacist, know that you have narrow angles, that either your ophthalmologist or the optometrist told you about it. You want to be aware of herbal supplements that sometimes can affect pupil size. And again, read the label. You can't.
I'm really glad you brought up something. So there's a case that I'm aware of where a patient was told by her optometrist that she had narrow angles, told the patient to come back for an exam, never came back. Then they went to another eye doctor a year later. That eye doctor said, I think your eyes are narrow. I think you should see an ophthalmologist for a gonioscopy to see if you really need laser. She never did. Then one day she developed sudden headache, pain in the eyes, but not really specific and not a red eye, but she was vomiting and very nauseous, went to an emergency room. And despite telling the emergency room doctor that she had a history of migraines, and a history of having her ovaries removed and her uterus removed and high blood pressure, she neglected to tell the emergency room doctor that she was told she had narrow angles. So guess what? She was admitted to the hospital, treated for migraines for a few days. And then a few days later, when her eye became red and she started to lose vision, that's when an eye doctor was consulted and they discovered she had narrow angle glaucoma. So patients have to be their own advocate. Like Carl said, if you're aware that you have narrow angles, you need to tell your doctors. If I tell a patient you have narrow angles, but you don't need treatment, that's me telling them you can use antihistamines, you can do whatever you want, but I'm going to see you once a year. If you don't come back, well, that's a problem because your angles could become more narrow with age. And as Carl mentioned, when you develop a cataract, it crowds the angle. So if you're a 64-year-old person and you have a slight cataract, and now your angle is getting more and more narrow every year, you need to see your doctor. That's most important.
Right. And as we mentioned, the laser creates a safety valve so that you don't have to worry about it anymore.
Right.
And most the way John and I were trained, we do it under the eyelid so that that glare doesn't bother you where the
Actually,
hole,
Carl,
very
that's
small hole.
changed. That's changed.
Is that right?
Yeah, it's good. I'm glad you brought it up. So we'll talk about the one risk I saw a lot more in my early career, which is like Carl said, we would make a hole in the iris. That's the colored part of the eye. And we were all trained, the guys our age, were all trained to put it at around 11 or 12 or 1 o'clock because it made sense. Your eyelid covered that little hole. So theoretically, it covered the light coming into your eye. But we still would see patients that would notice it. So a very smart guy, about, 15 years ago, maybe 20, he discovered that if you put it at 3 o'clock or 9 o'clock, for some reason, even though you would think intuitively the opposite, they don't have those symptoms. So it's just that I think the eyelid sometimes covered it, but then it would open up. Then patients noticed it. Whereas if it was there all the time, they learned to tune it out. So now for many years, I put it at 3 o'clock, 9 o'clock.
So this is why you don't see an oculoplastic guy for a laser iridotomy. I stay in my lane.
Stay in your lane, yeah.
But so listen, thanks so much, John. We shared some really good information. And thank you to our viewers for joining us on Einstein's Eyes. If you found this conversation helpful, please like, share, and subscribe. And until the next time, take good care of your eyes.